everybody, my name is Arman and today I'm going to be trying to explain to you lipid-lowering drugs in the best way that I can. So first of all, let's go over the classes. You have HMG-CoA reductase inhibitors, you have cholesterol absorption inhibitors, you got fibrates, you got PCSK9 inhibitors, you got bile acid sequestrants, and finally mepomercilin and luminapide. Now, LDL-C reduction is usually the main goal due to its primary role in atherosclerotic plaque formation. A healthy lifestyle is the first step in management, so before you administer any drugs, you want to make sure that the patient's exercising, that they're eating healthy and stuff. And if you do have to administer a drug, the first choice are statins. Now, a general guideline is for every 1% reduction in cholesterol levels, you have a 1% reduced risk of atherosclerotic cardiovascular disease. Now first let's talk about HMG-CoA reductase inhibitors. So they are analogs of HMG-CoA. What does that mean? That means the drug is shaped just like HMG-CoA so that it can occupy the enzyme HMG-CoA reductase. So it strongly reduces the LDL cholesterol, LDL-C. It also reduces things like triglycerides and it increases HDL, which is the good cholesterol that we want. They are the second most potent drugs and only PCSK9 inhibitors are stronger. We're going to talk about those later. They're orally taken, ideally before bedtime, because keep in mind, cholesterol synthesis happens while you're asleep. Like a large portion of it happens when you're asleep. There's low bioavailability of it due to first-pass metabolism due to this enzyme in the liver, CYP450, and it's excreted in the bile. So you might take, like for every 1 gram of statins you take, probably like 0.7 of it's just gone. It's metabolized instead by the liver. It's the first choice in primary prevention and immediately started after acute coronary syndrome, regardless of lipid levels. So first let's talk about this. So there's these concepts that we call primary prevention and secondary prevention. Primary prevention means that you are at risk of a heart attack. You've never actually had one in your life, but you're entering the age, you're entering the risk factors where it becomes a concern. Primary prevention is preventing it from ever happening in the first place. Secondary prevention is that you've already had a heart attack, and now we're trying to prevent any further damage and trying to prevent any further incidents from happening. So here's the potency list. So pitavastatin, rosuvastatin, and atorvastatin, these three are the most potent of all the statins. Then you have simvastatin, lovastatin, and pravastatin. These three, they're not as strong as these three, but they're still pretty good though. And finally, fluvastatin. This is the least potent of all the statins. So here's the mechanism of action, alright? I want you to focus on this part right here. So we have acetoacetyl-CoA, which in turn turns into HMG-CoA, which turns into mevalonate, and finally, after a long process, leads to a bunch of different outcomes, one of which is cholesterol, alright? This is the normal pathway that it takes in your body. HMG-CoA reductase is the enzyme that catalyzes this process from HMG-CoA to mevalonate. This is the rate-limiting step, in fact. And that's what causes this whole reaction to go through, right? Now, this is where statins come in. Statins come in right there. HMG-CoA reductase blocks that enzyme. What happens when you block that enzyme is the rate-limiting step. The entire reaction slows down, and you have a much lower synthesis overall of the cholesterol because you block this enzyme, right? Now, I want you to know that the way statins work is actually a twofold mechanism. So one is, of course, you're lowering cholesterol synthesis, right? That should be obvious. But the other way is once cholesterol synthesis is reduced by the liver, the tissues in the body sense the reduced cholesterol, and so they increase their expression of LDL receptors. So what they do is they pull the cholesterol out of the blood and into the tissues, which is what we want, because cholesterol in the blood is really dangerous, but in the tissues it's fine. So it's a twofold mechanism. One is you reduce cholesterol synthesis, and two is you increase LDL receptors, which increases the absorption of cholesterol from the blood into the tissues, where it's good. So here's the side effects and considerations. Now, when it comes to statins, the hallmark side effect, the most important thing you have to worry about is muscle weakness and discomfort, alright? Patients might be complaining of things like muscle cramps, of muscle weakness, they feel like they can't get up, and it's all due to the statins, right? Now, you want to confirm this with a CK level test, okay? Now, if the CK, creatine kinase, is slightly elevated, it's okay. That's no biggie. It happens physiologically. Let's say a guy's exercising, he's going to the gym, he is going to have a slightly elevated CK level due to like the muscle repair that's going on. However, if it's a vastly increased the creatine kinase level, it's a sign of rhabdomyolysis. And that increases the risk of renal injury and myoglobinuria if it's not stopped. So if you have a patient and they're complaining of muscle pain and muscle discomfort, and you check their CK levels and it's extremely high, you stop the statin right now. Just instantly stop it and prescribe a different drug to them. because, yeah, it's dangerous. And finally, it also has a higher risk if given with CYP inhibitors, which makes sense, right? Because CYP is the enzyme that metabolizes these statins. So if by reducing CYP, you're increasing the level of statins in the blood, which just means increased toxicity. Now here's some other symptoms though, some other side effects. You can have increased ALT and AST levels, which is a sign of hepatotoxicity. And if it's too high, you either lower the dose or you change the statin. It's uncommon though. Like this type of thing, it only happens to like 1, 2, 3% of patients really. And it's mostly associated with alcoholics and patients with liver disease. So notice that the increased ALT and AST levels is associated with alcoholics and patients with liver disease, as in people who would already have trouble with their livers are prone to this side of thing. It's not very common. And of course, you have GI disturbances, just like every other drug on the planet ever. It's contraindicated in pregnancy and breastfeeding, category X, and patients with active liver disease. This part should be obvious, right? That's it for statins. Now we're going to talk about cholesterol absorption inhibitors, with the only notable drug being ezetimibe. So they're orally taken. They're metabolized by the liver and they're excreted in feces. Now, it inhibits cholesterol absorption from the intestine, as the name suggests. It's a weak agent on its own, but it's mostly used alongside statins due to the synergy. It's the most commonly prescribed LDL-C lowering drug after statins, and usually there's combination therapy used with statins for patients with primary hyperlipidemia. Combination therapy with fenofibrate for patients with mixed hyperlipidemia. We're going to be talking about this drug later. Used for secondary prevention after acute coronary syndrome, right? So here's the mechanism of action. It's pretty basic, all right? So let's say this part's the intestinal brush border, while this part's the bloodstream, right? There's this one protein here that we call Niemann-Pick C1 like 1 transport protein. This is located in the intestinal brush border, and this is the protein that transfers cholesterol from the lumen of the gut into the bloodstream, right? Niemann-Pick C1 like 1, NPC1L1. So when this is around, cholesterol enters through this, it's because it's a transport protein, it enters the bloodstream and everything is fine, right? How does the ezetimibe work? Comes right here, boom, blocks that. By blocking that protein, what happens? Cholesterol is not absorbed, and it just goes through the intestine. Pretty basic, to be honest. Ezetimibe isn't a very complicated drug. One more thing I want to mention, though, is that you might be thinking, okay, so that means if you lower your intake of cholesterol, you won't really need ezetimibe since it's blocking absorption, right? That's true, but keep in mind that ezetimibe is still functional even when you don't eat any dietary cholesterol. And why is that? Basically due to the bile. The bile acids that are secreted into the intestines by the liver are very high in cholesterol. And when you're reabsorbing those bile acids, this drug, ezetimibe, prevents the cholesterol portion of the bile acids from being reabsorbed. So it's still effective in reducing overall cholesterol absorption of the intestines. So here's the side effects. Overall, it's well tolerated, but it can cause diarrhea or increased liver enzymes when taken with statins, right? Remember liver enzyme statins, so that's something to keep in mind. The concentration increases with fibrates, so consider dosages if taken together, alright? And it's contraindicated in patients with active liver disease who are taking statins already. Notice that. So the ezetimibe itself is relatively safe, it's not too bad, but when taken in combination with statins, it could cause some problems, so you want to keep it pay attention to that. Let's talk about fibrates. The two drugs here are gemfibrozil and fenofibrate. Now, what do? They strongly reduce VLDL and therefore triglycerides. It weakly reduces LDLs and increases HDLs, which is the good one, that's what we want. It's mostly used in severe hypertriglyceridemia, and it's absorbed efficiently and excreted mainly the urine. Now, what's the mechanism of action here? It's a bit complicated, but I'm trying to simplify it here, okay? Here's the DNA, right? You can notice the DNA. And on the DNA, we have this little receptor. It's called peroxisome proliferator activator receptor alpha, PPAR alpha. What is this? It's just a transcription receptor, right? And what do fibrates do? Fibrates come here, they basically permanently activate these genes. Like they act as a ligand and they keep on reactivating this receptor again and again and again. So what does that lead to? That leads to increased transcription of certain proteins, resulting in what? Increased lipoprotein lipase, of course, which what does that do? It breaks down chylomicrons and VLDLs, right? So reduced plasma CM and VLDLs. It increases the ApoA1 and ApoA2, which increases HDL, which is good, that's what we want. It reduces ApoC3, which means there's reduced inhibition of LPL, which means this can increase again. And finally, there's increased fatty acid oxidation in the liver and striated muscle, which leads to reduced VLDL. So this is how fibrates work. They're pretty much like the drug that activates all the good pathways we want in terms of fat breakdown. By the way, if you want to remember the mechanism of action, the way I remember is fibrates, four rates. You get it? The fibrates drug works by increasing or reducing 4 rates. So rates. It helps me remember it. Maybe it'll help you as well. So here's the side effects and considerations, alright? So it can cause GI disturbances, it can cause increased risk of gallstones due to increased cholesterol in the blood, in the bile. It can increase the chance of myopathy if administered with statins. Remember, statins and myopathy, that's that's a hallmark feature right there. It increases the effect of warfarin, so you want to check for a PT closely. It's contraindicated in children, pregnant women, and patients with renal dysfunction. Why renal dysfunction? Because remember, it's excreted in the urine, so getting a lot of this in a patient with renal dysfunction could be very dangerous. And if you're co-administering it with a statin, fenofibrate is preferred, because gem fibers will greatly increase the risk of myopathy with statins. So remember, myopathy statins are a huge, they happen together a lot. Gem fibers will increase that risk by a lot, so you prefer fenofibrate in that situation. And you closely monitor the CK and liver function tests. Let's talk about this. Proprotein convertase subtilisin kexin type 9 inhibitors. We're just going to call them PCSK9 inhibitors. So basically they're antibodies against the PCSK9 enzyme, which I'm going to explain soon. It consists of alirocumab and evolocumab. By the way, just a little hint, anytime you see umab at the end of a drug, what it means is the drug is an antibody. Alright, so that's why a lot of anti-cancer drugs in this umab, because they're generally monoclonal antibodies. So it's a very expensive drug, and it's administered every 2 to 4 weeks subcutaneously. It's used in patients with familial hypercholesterolemia. Remember this term, we're going to be seeing it again later this lecture. And it's especially useful when patients are already on a maximal dosage of statin and ezetimibe therapy and still need further LDL reduction. So it's very expensive, and you mainly use this drug if you already have them on the maximum dosage of statin and ezetimibe therapy that's safe, but they still need further LDL reduction. Then you give them PCSK9 inhibitors. Now, how does this work? It's a big complicated process, but honestly, all you need to know about it is this. There's the so here's a liver cell, and there's the bloodstream, right? On the liver cell surface, you have an LDL receptor. Okay, and what do? They suck in cholesterol from the bloodstream into the cell, right? PCSK9, in essence, what it does is it comes and it prevents this LDL receptor from working, right? It basically inhibits that receptor. So that's what PCSK9 does. What does PCSK9 inhibitors do? Comes here, boom, stops this. It degrades this enzyme PCSK9, which allows for increased expression of LDL receptors, which reduces the LDLs in the bloodstream. So side effects aren't too bad. They're pretty basic. So it's flu-like symptoms and upper respiratory tract symptoms, so patients might feel a little sick, and injection site reactions. So that's about it though. So now we're talking about bile acid sequestrants, also called resins. So they consist of cholestyramine, cholecystopol, and cholesevelam. These are really old drugs. These are some of the earliest and lipid-lowering drugs that we have, and they're mainly used nowadays if the other drugs don't work. So they're used sort of as a last resort, as a desperation move because the other drugs aren't working, right? And essentially how it works is they're positively charged ions, and they bind to the negatively charged ions in bile acids, preventing reabsorption of the bile acids. So here's how it goes, right? You got the liver here, you got the GI lumen here. What happens? The liver has the bile acids, secretes it into the GI lumen, it comes down here, and eventually it gets reabsorbed back into the liver, right? It makes sense. Now what do resins do? They come here and boom, they stop that. They stop reabsorption of bile acids. Reabsorption of bile acids that include a lot of cholesterol means there's less cholesterol to be reabsorbed into the body. It might remind you of ezetimibe, to be honest, because they actually have a little bit of a similar function where cholesterol is not absorbed from the GI lumen, especially in the case of bile acids. So here's a side effect. So mainly GI side effects due to its action in GI. That should make sense, right? It mainly works in the GI. The main side effects include constipation and bloating. There's steatorrhea if the patient has a pre-existing bowel disease. An important one is that it can cause malabsorption of vitamin K, leading to hypoprothrombinemia. So prothrombin times should be measured in patients taking resins. They can also interfere with the absorption of other drugs like thiazides, digoxin, and warfarin. So you don't take those drugs in the same time frame as resins, So if you decide to take resins, you don't take the other drugs right after. You might want to wait like 4 or 5 hours afterwards to take those drugs safely because they won't be absorbed if you take them with resins. And they can be used to treat diseases caused by bile acid accumulation. So think of something like, like gallstones, that kind of stuff, right? It can be used to treat those conditions as well. Let's talk about lomitapide. So what does it do? It inhibits microsomal triglyceride transfer protein, MTP. What does it do? Basically, what MTP does is it adds triglycerides to VLDLs and chylomicrons, okay? So by inhibiting this, you mean you inhibit adding triglycerides to the VLDLs, and that means reduced synthesis of triglycerides. And it's reserved for patients with homozygous familial hypercholesterolemia. Remember what we talked about earlier? These patients, they need as many drugs as they can get. Lomitapide is especially reserved for them. If you don't have this condition, you won't be prescribed this drug. And of course, it's very expensive. Finally, mipomersen. It's basically an inhibitor of ApoB100 synthesis. And what is ApoB100? It's a structural protein for VLDLs, IDLs, and LDLs. And it's also a ligand for LDL receptors required for assembly and secretion of VLDLs. So basically, it's a structural protein in VLDLs, IDLs, and LDLs. And it's also responsible for secretion of VLDLs into the bloodstream. And just like lomitapide, it's reserved for patients with homozygous familial hypercholesterolemia. It's very expensive. And I mean, that just about wraps it up. I think I covered all the drugs reasonably well, and I hope this video helps you. Bye-bye.